We're going to be talking about catatonia today, and I was totally stoked when Tim asked me to talk about this because I love catatonia, as some of you may know. And I also hope by the end of this you will identify that you should be loving it as much as I do, because it's actually something that I think we don't realize we're seeing when we're actually seeing it quite often on our dialysis or our units on the inpatient center. So what we're going to be talking about today is the epidemiology, like who is it that gets catatonia, what's it often most associated with, and then how do you pick it up and how you treat it. So those are all the things we're going to be talking about. And I think it's super awesome that I'm talking with you guys about it, because who spends more time with the patients, you guys or the docs? You guys buy a ton, right? So my hope is, my expectation is that if you guys are well versed in catatonia, you're going to be picking up cases that the team may be missing because they may not pick it up in that short time potentially that they're spending with the patient. So that's what we're going to be talking about. So the definition of catatonia is a neuropsychiatric syndrome. So syndrome being it's not a single thing, it's a whole constellation of things. And you see a change in mental status with patients, and you also see motoric findings. So we'll talk about the different kinds of catatonia, but the motoric finding people most often associated with catatonia is what? What is the motor finding you think of when you think of catatonia? How do you think the patient's going to look? Stuck, just like frozen, right? So that would be psychomotor retardation, kind of a stuck type of catatonia. And that is one type, and we'll talk about that. But there's other types as well. Another take-home point is you can see it associated with essentially anything, and we're going to cover that when we have a slide specifically about this. You can have catatonia associated with psychiatric disorders. You can have catatonia associated with autoimmune disorders, with neurologic disorders, with all kinds of things, which is why I was saying earlier that I think it's great that they're letting me talk about this, because I think sometimes people have certain things that they associate catatonia with, and they think, oh, if the person doesn't have that, then they must not have catatonia. But that's actually not true. So that's why we're going to be, one of the reasons we're going to be covering that today. So audience participation, I will not have you guys pretend you're catatonic, although that would be really fun. For how many of you have received training on the diagnosis of catatonia, like learned about what it's about, how you treat it, that kind of thing? So how many? A show of hands. So I've seen 2, 3, a little bit. So I was a medical student here. I started medical school in '96 and finished in 2000, and finished residency in 2005. And during that time, I was never taught about catatonia. I heard the word catatonia, and people would throw around, oh, you know, there's this catatonic thing, whatever. But I never had one single patient given a diagnosis of catatonia or treated for catatonia, even though I clearly had patients with catatonia. They would even have patients when I was at the UW, this happened. I had a patient who was clearly catatonic, and they would describe the patient as appearing catatonic, but never gave a diagnosis. And just by luck, we ended up treating her with ECT, which helps with treat catatonia, but only because nothing else had worked for her. It wasn't because they were thoughtful and this is what she has, this is how you treat it. So that's why I think it's important that we're talking about it now, because I think this is an area that has really been lacking in our training. And again, as you see from the data, this is something we see a ton, whether we actually realize we're seeing it or not. What was the first year that catatonia was described? Like by, it was actually a doc that described it. Anyone want to guess?
1903.
1874. Wow, are we slow at the pickup, right? This is not like this is a new thing. This has been around a really, really long time. It's just gotten more attention recently, and I'll talk about why that is. So catatonia is divided into 3 types. This is the one that when I asked about what people associated with the psychomotoric changes, this is what people most often think of. These are the patients who are just stuck. Like you walk on the unit, you could immediately tell that person appears catatonic. They're not talking, they're staring, they're not saying, sometimes they're posturing in an odd way. So that's what most people commonly associate with catatonia. You can also have an excited type. These patients are a little bit trickier to pick up because you can attribute what they're doing to all kinds of other things. There's not many things that you can attribute a true withdrawn catatonic to, but there are lots of things you could attribute an excited catatonic person to. So the classic is motor behaviors that don't have purpose. So like I have a patient that's on the unit right now who's getting ECT, a court-ordered ECT for catatonia, and when you talk to her, I was talking to her and this is what she's doing. Like there's no purpose, there's no reason to do this. Certainly people will do things because it does something for them, right? Like they have an itch and so they scratch, or there's a purpose to that movement that they do. Sometimes they have people who have repetitive habits that they do. Some people are foot tappers or wigglers or something, but you ask them, they say, oh, I just do that all the time, I'm a foot wiggler. So this is purposeless movement that the person's engaged in. Disorganized or overprotective speech. So this particular patient, often I would say something, say something, say something. So I'd have, how are you? Fine, fine, fine. So she would repeat what she said multiple times, which can be overproduction of speech. She also had this really cool stuff that she would do with her hands. She's not doing it as much now, but I was talking to her, she'd go like this. Very odd stuff with her hands. And when I would ask her, like, you're moving your hands, why are you moving your hands? I don't know. So they can't tell you why they're doing things. Someone with akathisia can look agitated. What will they tell you when you ask them why they're moving? I can't stop. I feel uncomfortable in my skin. I feel like I have to move. They can tell you why they're doing that. Where someone with catatonia is like, I don't know why I'm doing that. I'm just doing that. No real reason they can explain. Patients can be some of both. Patients can start out one way. The patients that I'm giving ECT new, quarter to ECT for catatonia, she started withdrawn, then she ended up agitated, and now she's in a mixed state. Sometimes she's a little bit frozen, a little bit latent. Other times she's overproductive in her speech, and she has this disorganized behavior that she does. So you can be a mixed, and this is why sometimes it's hard to pick up. If they're mixed or have the agitated type, sometimes you're not sure what it is that this person's doing, so you may not actually realize that it's catatonia that you're seeing. And it doesn't have to be all at one time. Patients can exhibit this and change in a day, so they may look different in the morning than the afternoon, than the evening, than in the middle of the night. So it can wax and wane a bit, which is why you need to look at not just a snapshot, and that's why it's so great that you guys are learning more about this, because you guys spend a lot of time with these patients and might pick up stuff that the team may just not see in the short time that they're actually with the patient. So this study has been replicated in China, Australia, Wales, in the US, on and on and on and on. 10% of patients that have the kind of diagnoses of our patients meet criteria for catatonia if you go on their units and do diagnostic tests, if you actually do catatonia exams. In the history of Harborview, do you think that there have been 6 patients that have been diagnosed with catatonia at the same time? I don't think so. Maybe at this moment, just because I'm on service and I've got 3 people I've identified with catatonia on my team. Outside of that, probably not. So either Harborview has an inpatient service that is completely unique, that is not like any other psychiatric hospital in the entire world, one option, or 2, it's in front of us and we don't know we're seeing it. Probably the latter, that it's actually in front of us and we don't know that we're actually seeing it. So, who gets it? What's the most common diagnosis associated with catatonia, psychiatric diagnosis?
I'd say it seems like psychosis.
Right, so psychosis or schizophrenia is the most common one that people would identify. It's actually bipolar disorder. And I think part of that is left over from the previous subtypes of schizophrenia. There was a disorganized schizophrenic, there was a catatonic schizophrenia. So it automatically makes you think, well, it's in the name. That must be the most common thing it's associated with. It's actually mood disorders, particularly bipolar disorder, is what you can see it with. You certainly will see it with people with schizophrenia. I have a patient on the unit right now who's schizophrenic and also is catatonic. But it's important to realize that bipolar is actually a risk factor for developing catatonia, is having that diagnosis of bipolar disorder. Other conditions, like I talked about, neurologic disorders, encephalitis, stroke, TBI, MS, seizures, general medical conditions, essentially anything you can think of. I was giving a catatonia talk to a group of medicine docs, and they asked, we talked about the conditions that you can see associated with catatonia, and I actually showed them a list, and it was more than 30 diagnoses. So you really can see catatonia associated with almost anything. So I think an important thing to think about is, yes, it's more commonly associated with certain disorders, but if you don't see a disorder that you think is associated with catatonia, it doesn't mean that the person isn't catatonic. The second patient that I ever diagnosed with catatonia when I was first attending here, at the end of her stay with us, the only diagnosis she had was catatonia. She did not have a mood disorder, she did not have an anxiety disorder, she did not have substance disorder, she had nothing other than catatonia. So sometimes you'll see it and we don't know what the underlying cause is, but people can get catatonia. So why do we miss a diagnosis? We talked about this one already. We just talked about this one. This is an important one. It's one of those things, it reminds me of tardive dyskinesia. I was recently rounding with my team, and I had a resident that was a second-year resident and medical students with me. And they'd interviewed the patient, and the patient left. And then I said, have you guys seen tardive dyskinesia? And they said, no. And I said, you just did. The patient that had just left the room had TD, but it was not the really prominent symptoms of TD, but the person would meet criteria for tardive dyskinesia. They didn't see it because it was more subtle. The patient had some puckering, a little grimacing, a little bit of tongue darting when they were talking, a little bit of jaw sliding. It was there, and it's one of these things that once you get used to looking for catatonia, you see it. When you're not used to looking for it, like it's literally right in front of your face, just like when I was a resident and they were identifying patients as having catatonic features, but they weren't giving them the diagnosis. So I think it's important when you hear that there's a catatonic patient on the unit, whatever unit you're on, go look and see what the patient looks like. And the more you get used to looking for catatonia, the more you actually start seeing it, because you start to see the subtler versions of it instead of the really frank cases that we see where the person's like stuck frozen in the hall or something like that. We misattribute it to another symptom or another condition. We talked about akathisia, depression, for example. Depressed patients usually, does it take them longer to answer questions when you're talking to a depressed person? Oftentimes, yes. So there is some latency there. So how do you know that this latency, this kind of avolition that depressed patients can get, this kind of, all the negative kind of stuff you can see associated with depression? So I had a great case of this. I had a patient who, very bright woman, she had schizophrenia, and when she was in a decompensated state, she'd cut her nose off and swallowed it. She'd eaten the neighbor's cat's eyes. I mean, she was very sick when she was sick. And she came into the hospital depressed and suicidal. And I was interviewing her, and I thought, man, she's so depressed. She's so latent. And I thought, man, her latency seems like out of proportion to her depression. Like she was really latent. And so I asked her, I said, I'm noticing that when you're talking to me, that it takes a long time for you to be able to answer the questions. Is it hard for you to get your words to come out? And there was this long pause, and then she goes, yes. Like she was so frustrated. She wanted to get the words out, but she just couldn't, right? So I said, I'm gonna stop talking to you right now. I said, I'm going to ask the nurse to give you some lorazepam. I think you have something called catatonia. I'm going to come back in about a half an hour and see how you look. So stop the interview, ask the nurse to give her some Ativan. And then I went and saw her in her room a half an hour later, and her speech was completely fluid. No latency at all. And then she fell asleep. So then I had to switch her to diazepam, which some people who get really sleepy from lorazepam, so you get stuck kind of on how much you can give them, you can switch them to diazepam and they might not get as sleepy. So she was depressed, but I could tease out whether her latency was from depression or whether it was related to something else, which in this case was catatonia. And then we talk about the akathisia. Patients can tell you about that if it's akathisia. So it's a bad thing to miss, which is another reason why I'm excited I get to talk with you guys about this. So for some patients, it's a self-limiting experience. Just like a manic episode can be a self-limiting experience, just like a depressive episode can be a self-limiting experience, an exacerbation of someone's schizophrenia. Their psychosis can be a self-limiting thing. So sometimes people get better even if we don't intervene. But does it take a longer time for a manic episode or a depressive episode to get better if there's no treatment? Yes, it does. And the same thing is with catatonia. Some patients can be sick not just for days, they can actually stay stuck for years until the catatonia is diagnosed and treated. So there's a very sad case report done by Bush Francis, the DIAD, which had the rating scale, which we'll talk about, of a woman who was in her 40s that had bipolar disorder and had come into the hospital depressed. And at one point she'd been treated with ECT and had a good reaction, good response. And then another time she came in and they gave her some lorazepam. But then when she was in the hospital, unfortunately, they thought she looked impaired cognitively, so they did a consult with neurology, and neurology said she's actually got dementia. So they sent her home with her family and so she was married and had 2 young daughters. For the next 7 years, she sat in their house like a potted plant. She got down to 80 pounds. She was mute, postured, no interaction with people. She just withered away. For 7 years she was in this state. And then she was so ill, they finally hospitalized her again. And while she was there, they had psychiatry come and see her, and they said, well, maybe we should just try treating to see if we could help anything to try to get her, like they thought she was in this severe vegetative state and they thought she'd try. So they did ECT. And after the second or third treatment, she started talking again. And then she started looking better and better. And then when her daughters came in to see her, she didn't know who they were. She had not laid down memories. She could not believe that her children were little children in her mind, not these young women that had grown in the time she had been totally stuck. They treated her, no cognitive deficits. She completely came back. She needed intermittent lorazepam or ECT or else she would start to get stuck again. That was life-altering, her course for catatonia. So it's one of the things we're going to talk about when we talk about identifying catatonia and treating. Even though patients can get better on their own, I think we can get them a lot better, a lot quicker if we identify what's going on and treating them. And for some patients, if we don't, they can stay sick a long, long, long time. And if you look at old footage of psychiatric hospitals or images of psychiatric hospitals, you will see tons of catatonic patients. All these people in these really weird postures, which I'm going to show you some pictures of, because there were lots of people that were catatonic and they didn't know how to treat it. So I think it's a really important thing to treat because it can be really a big thing. It might not get better on its own without treatment. So this is an example of one of those pictures. So this is someone with something called catalepsy, which is patients will put themselves in odd postures that go against gravity. Like if you guys, I know what all of you would do if you became unconscious. You would slowly slink to the floor and lay on the ground, right? We kind of automatically go to the energy level that takes the least amount of energy. These folks will get themselves at times into these weird postures that clearly are taking a huge amount of effort, but there's no reason that they can tell you or that you can understand that they get themselves into. We had a great guy in the Pez did this one time. He came in, he had catalepsy, and he was laying down his gurney and he would float his arms up. And his arms would be up there for hours, and his arms would shake and shake and shake. And we'd gently go and put his arms down, and as soon as we released his hands, what did they do? Floated right back up, right back up. I was like, what are you doing? Yeah, I don't know. This is so interesting. So, for diagnosing catatonia, unfortunately, the DSM did not go as far as some of us hoped in the DSM-5. They still have catatonia secondary to other things. Catatonia secondary to a general medical condition. Catatonia secondary to a psychiatric disorder or an NOS diagnosis. It didn't have catatonia all by itself. We were really hoping that they would get a classification all by itself, because I think it would free people up to make the diagnosis when they don't see these other diagnoses that people often see associated with catatonia. So this was better than it was before, though. So usually the diagnosis is based on 3 cardinal symptoms, and it's within several hours to 24 hours, which again comes why it's so important for you guys when you're seeing stuff to document it in the chart. So when we're looking through the chart, we can kind of pick up stuff that we may not be seeing during the day when we're there with the patient. And these are, when I mentioned earlier that Bush Francis, these were kind of the godfathers of modern catatonia detection. This is the screening scale that they came up with. I think there's 23 items. I have never done a full Bush Francis on someone because it takes too long. But it's important to just be aware that there's a whole bunch of things that you could be thinking of for these patients. The ones where that they have the star by them are identified as cardinal symptoms. So things often that are classically associated with catatonia. And the thing I want you to notice is some of these are psychomotor retarded and some of them are agitated. So stereotypic behaviors, that's going to be something that's agitated. Perbiduration, where they're repeating stuff over and over and over. So these are kind of more activated catatonia. So this is the big scale that no one uses. And these are some pictures I wanted to show you. I actually, when I was talking to Tim about this, Tim and I talked about me putting video clips of people with catatonia so you guys could see. The problem was all the video clips were uncomfortable to watch because of the way the providers interacted with the patients. So there was no like gentleness when they would come. They would just like come over to where the patient was and like move him in a direction, then stand back and then look at him and move him in another direction and stand back. It was very, it felt uncomfortable and exploitive. There was only one that wasn't, where the doc, well, it's still a little uncomfortable, but the doc interviewed a patient that had echopraxia, which is what you copy the behaviors that the person's doing. So the doc would be sitting there like with his legs crossed, and then the patient would cross her legs, and then he would like make an exaggerated movement like this, and then the patient would go like this. It was just like fascinating, but it also still again felt a little funky, so I didn't. So I'm going to show you guys catatonia. So these catatonia exams. So these, you can see how these people are in these weird positions. They put themselves in these odd positions. And I remember as a resident when I came on to Five Center, seeing patients that had catalepsy. In retrospect, seeing these patients walking when I'm going through the unit and seeing patients that were in these weird postures, I thought, what are those patients doing? You know, I didn't know what it was that I was seeing at the time. So this is the exam that I do. And I would encourage you guys to learn to be comfortable in doing this as well. It's a really short exam. So the first thing you need to do is observe the patient. So when I'm talking with the patient, sitting across from them, first thing I notice is blink rate. So one of the things that patients will do is they'll blink excessively or they stare. Don't blink, don't blink, don't blink. So what I do is I match my blink rate to their blink rate. And if I notice I'm blinking a lot, then I know they have increased blink rate. If I notice myself kind of like trying to force myself not to close my eyes, then I know that they have reduced blink rate. The other thing I'm looking at is how silent or active their body is. So all of you are moving right now. They're very subtle movements that you make, but there's a lot that we do a lot of shifting. A little bit of their head or just one way or another. It's very common for us to do that. So if you look at someone and there's no body movement, this is atypical. This is someone who has some psychomotor retardation and may have other findings when I do the exam. So that's the first thing. And then I'm just kind of talking to them, saying, you know, I'm going to be doing this thing where I'm going to be moving your arm and just kind of checking to see. And I see if they start doing things like like they're mute, or there's a lot of latency, so it takes them a really long time when I ask them if it's okay if we do this exam, or if I notice they're repeating what I'm saying. So you can get a lot of information just by this much alone. Then you're going to feel like totally like a gooner when you do this next thing, but it's like amazing when you get a positive on this. So without telling the patient anything, you go like this. And I can't tell you how many patients I've had. They just like raise their hand up and then they scratch their head. And my inside voice is like, what are you doing? Why are you doing that? It's so interesting. So that's called echopraxia. I did have one patient that was starting, I noticed when I was talking to her before I did the exam, I was shifting my legs across one side to the other, and she was doing it as well. And I thought, oh, she's gonna do it. And she did it, which was awesome. Next thing I do is check for cogwheeling. So I come over to the patient, of course, after I've gelled, and I take their hand, and I'm just trying to move their hand. Negativism is the person will just completely resist my movement. So they'll like be stuck, like they will not let me move. And my patient that I'm giving ECT to the court order DCT to, she had a day where she had negativism. I was trying to move. She was complaining about something uncomfortable, so I was trying to help her move, and I tried to move her arm, and it was completely stiff. Like she would not let me move her arm. It was completely negative. You can also check for waxy flexibility. So like I'll be moving their hand, and normally when I'm checking for cogwheeling, I jerk their arm really quick, but I'll like take their hand and I'll just let it go. And someone with waxy does this. They keep their arm exactly where I left it. And then if I notice that, I'll position it in a different way and see whether they hold it. Normally what happens if someone releases your arm, you like hold it there a second, then you're like, oh, and then you just put it down. So and catalepsy is where they put it in a weird position themselves. Gegenhalten is so cool. So when I'll be moving them, I'll push a little bit to move their arm, and they'll push against me with equal force. And I push twice as hard, and they push twice as hard against me. So they'll let me move them a little bit, but then they push me back that much. It's really cool when you see that. It's so awesome. Then I do this next test, which is so fun when you see a false positive. So you say, you have them extend their arm straight out, and then you say, don't let me move your arm. And you touch their hand really lightly, and they go like this. They don't do this part. That was my part. It's so interesting. That's called the ankle poise lamp. Then you say, you say, don't shake my hand, and you reach out. And that's why I do this one, number 5, after I've done this, because I worry otherwise, if I've already done the thing about this shaking the hand, don't shake my hand, that if I do this, they may think, oh, I'm supposed to be doing this because she told me the commands on the previous one. That's why I do them in that order. So patients can have ambitendance where they'll like start to reach their hand out, and then they do this. And then they go like this, and they get stuck. Because I've said don't shake my hand, but my hand's sticking out, so they don't know what to do. And a patient that we have on the unit, the third woman I recently diagnosed with catatonia in the last week and a half, she had this. She was stuck in her room in between the door. Like she was in her doorway, and then she'd go like this. And she was like completely stuck. She was just like back and forth, and I'm like, we got to give you some Ativan right now. I like left the interview because it was like so painful watching her be so stuck. Then you check for automatic obedience by pretending you're going to take a pin out of your pocket and stick it in their tongue. So you say, stick your tongue out, I'm going to put a pin in your tongue. And then you pretend to take a pin out. Most would be like, I don't think you're going to be putting a pin in my tongue. I had a patient 3 hours after I did this exam, I had to go back and tell her to put her tongue in her mouth because she was still sitting with her tongue sticking out of her mouth after I told her this. And then you turn their hand over, and then you stroke their palm, and you look for a palm reflex. This is what do babies do when you do this? They close. It's a grasp reflex. That's a frontal disinhibition, so you get a frontal release, and you'll have some of those rudimentary reflexes that babies have can occur with people with catatonia, and that's one that you can see. So this is an exam. How long do you think this takes to do? 5 minutes. Once you've done a couple, it takes 5 minutes. So it's a really good thing to get comfortable doing, and then you can get them done. Doesn't take any time, and you can kind of pick stuff up. So that's the exam. The other thing we do is look at the notes to see what's going on with the patient. I had a great example of this. I walked onto the unit, and there was a patient sitting in the dining room like this, with her hands just hovering over her meal. Went and saw a patient. 15 minutes later, what was she doing? Like hovering over her meal. So watching what's going on with eating can be helpful. And then I like, when I can, to just look at the patient to see what they're doing when I'm not observing them, to see if they're getting stuck or they're doing this weird stereotypic movements or those kind of things, because it can get all that information, can be helpful. The other thing is, if someone does something weird, then I also think of catatonia. Coming out of your room naked. We have some disinhibited patients that might do that, disorganized patients that might do that, but it's not a typical thing that patients do. Peeing on your floor, not a normal thing for people to do. Also, it makes me think, what's going on with this patient? Sometimes patients will do odd things. Patients with delirium can do some of those things too, but delirious patients aren't oriented consistently. You'll see the waxing and waning thing more than you'll see with catatonia. So all of those things kind of tip me off. So I'm going to have you guys do some audience participation. I am not going to make you do interpretive dance, although that would be awesome. Do they have a handout? There should be cases. Did Tim give you guys cases? I hope.
There's some.
Good. So there's case number 1 and case number 2. I want you to read case number 1, which I think is going to be passed out to you. And then I want you, and buddy up with somebody because it's not nearly as fun doing this by yourself. Identify everything in the case that you think could indicate catatonia. So I want you to just look at that, spend a couple minutes doing that. And then I'm going to have you guys come back as a team, and then we'll kind of review that. Pardon?
How do you want me to hand it out?
Everybody?
Everybody gets both.
Everybody gets both. Is there a case 1 and case 2, or do they put them on different ones?
Case 1's on one page, case 2, oh no, one on one side, one on the other.
Yeah, perfect. So just start with case 1, don't move on to case 2. So start with case 1 and then just a couple of minutes, review it with a colleague, identify or mark on there things you think could be related to catatonia, and then we'll come back as a group. I'm going to just read this line by line, and I want you guys to tell me anything that makes you think about catatonia. So, 28-year-old male with a history of bipolar disorder brought in by SPD after he was found sitting in a hotel lobby downtown and wouldn't leave. Yeah. So sitting in the lobby and bipolar disorder, right? So there's a couple things in the first sentence alone that you could think, something could be going on, maybe related to catatonia. He was evaluated and detained based on GD. Well, that's pretty nonspecific. So in the interval history, the patient agreed to meet with the team, but it took him several minutes to walk to the interview room.
Several minutes.
All right, so several minutes, so it looks probably pretty slow. He reported his mood was nice.
Nice.
Yep, so verbigeration, so repeating things over and over. He offered no spontaneous speech during the interview. All right, so that's not usual for our patients, unless they're like really pissed off at us. Sometimes, but you know that because they give you they give you that stink eye. When asked if it was hard for him to get his words out, he stared at you intently, and then after some time responded, yes.
It's the staring and then the delayed response.
Exactly, staring and then the delayed response, and then the response saying, yeah, it's hard for me to get my words out. Have you ever seen a catatonic person do this? It's so, you can tell like it's so frustrating. I always think that's how God will strike me. He'll cause me to be aphasic and I won't be able to speak. That would be a terrible thing for me. So this is, in looking at the nursing notes, the staff reported that the patient was found several times in the hall last evening standing motionless staring.
Motionless staring.
Yeah, so just standing in the hall. That's just not what patients usually do, not for long periods of time. They may hang out for a little while, but that kind of sticks out. When offered his meds last evening, he stared at them. And then when asked if there were any concerns about the medications, he answered no after more than 30 seconds and took the meds.
Delayed response, 30 seconds.
So delayed response, 30 seconds. And patients can have ambivalence toward taking their meds, right? Like they may not be so excited about taking medications, or maybe they're paranoid. That's a classic thing. Like the patient doesn't want to take the pill because it's red and green, and the ones yesterday were red. So they think there's something wrong with it. So I think sorting out to make sure it's not paranoid, it's the reason that person is actually not wanting to take it, can be helpful. After his labs were drawn, the nurse noticed his arm was still in the position it had been placed in by the phlebotomist, and then when she tried to place it at the patient's side, he resisted the movement.
That's it. That's all.
So what is it? There are two things there. What are the two? Resistance, and then he's stuck in one place. So he's got some waxy flexibility, and he also is resisting when you're trying to move him down. Excellent. So his vital signs, pretty unremarkable. These are the meds that he's on: lithium, risperidone, and lorazepam.
You see a lot of tachycardia now?
I put the tachycardia because of the risperidone. So risperidone is associated with tachycardia for some patients. Also, I worry, I wonder how this person is eating, because the person is kind of stuck a bit, so I would worry that they may be a little bit dehydrated, so maybe I want to get posturals for this person. They may just be tachy because they're dry. So it's another thing to think about. So this is the guy's mental status exam. Thin gentleman wearing hospital garb with food stains.
Food stains. You kind of hold your spoon there, it splats all over you.
And also I do think sometimes patients that a lot of our patients may not be paying attention to their self-care. And I think that's just one thing to keep in mind. How about behavior? Psychomotor retardation, stares with reduced blink rate, cooperative.
Reduced blink rate.
Yeah. Anything else? Psychomotor retardation. And I also think it's important that he's cooperative, because sometimes you'll have patients, again, that aren't very interactive with you, it's not necessarily that they're catatonic, is that they're not interested in interacting with you. But I'm saying this guy's actually cooperative. He appears to be wanting to interact. It just may be difficult. So there's this paucity of his spontaneous speech. We talked about that already. And then fine and constricted for his affect. We already covered the paucity of content in the other part. So that's his mental status exam. So that is case number 1. Now you guys get to do audience participation again. Is this not the best Photoshop slide? I'm just like, love this slide. It's like my new favorite picture. So I want you guys to go ahead and do what you did with case number 1, with case number 2. So read through it, identify things that might be associated with catatonia, and then we'll do the same thing we just did, discuss it as a group. So we'll do the same thing. 42-year-old woman with schizoaffective disorder was admitted for worsening depressive symptoms and SI. Anything in there? Yeah, schizoaffective disorder is an increased risk to have if you have schizoaffective disorder. For the interval history, patient agrees to meet with the team after taking a seat. It was noted that she was making repeated hand movements and straightening her fingers, extending them toward the ceiling, then closing her hand and making a pinching movement with her thumb and forefinger. Yeah, so this is it. This is what my patient was doing. It was really friggin' cool. So interesting. And then when asked why she was doing it, she said, why? I don't know. What do you think of that?
Repeated words.
Repeated words, and also, I don't know why I'm doing it. So it's actually both. So it's a repeated words and that she actually doesn't know why she's doing that. I've had certain patients that have OCD, and so they have a tapping or a complex motor thing that they're doing because it actually is reducing anxiety. It's part of their ritual. So for that, they could tell me, well, I'm doing this because I'm undoing the bad thought that I just had, kind of a thing. But that, not in this case. This is from catatonia, potentially. So while the team's speaking to her, it was noticing that she was making grimacing facial expressions, and she was denying any pain or distress. Right, so patients can do this, all this weird stuff that they do with their face, and it's like this grimacing, but there's not something causing them pain. They're not like in physical pain, but they're having these grimacing behaviors. The attending noticed that when she repositioned herself and crossed her legs, the patient repositioned herself and crossed her legs. Yeah. And that is denied SIHI. It had some AH. But nothing too remarkable there. So in looking at the chart notes, it was noted that the patient was seen getting out of a chair, walking a short distance, turning around, walking back to the chair, sitting down, and then doing it again. So repeatedly, what do you think of that? Yes, it's kind of purposeless, kind of repetitive behaviors for no good reason. And asked about symptoms of akathisia, she said no. Because again, that could be what's driving that kind of feeling that she has to move. When she was offered her medications for the evening, she put them in her right hand, and then she took them and put them in her left, and then she put them in her right hand, and then she put them in her left, and back in her right hand. She did this repeatedly, and then she took them. What do you guys think of that?
That's one.
Yeah, that's abnormal behavior. Like, this is not a normal thing that people are doing unless they have OCD. At one point, she came out of her room without any clothing on, but was able to be redirected to go back in and get dressed. Yeah, again, so that's also something that can happen. If she says, I just feel like, letting God, the whole world show me what God gave me, that would identify as bipolar patient who has to show themselves off, which isn't so infrequent, but not in this case. So it just shows blood pressure, heart rate, temp, which is, 12. One thing we'll talk about when we talk about the treatments, that one of the things that can happen if someone has catatonia and they're given a typical antipsychotic, it can drive them into kind of a malignant catatonia, which can become NMS, neuroleptic malignant syndrome. So just important to keep an eye on vital signs for people with catatonia. And that's not 100% accepted, but there is an increased risk, and there is some data which we'll talk about. So, mental status exam. Disheveled woman wearing street clothes. Cooperative, echopraxia, grimacing, repetitive purposeless movements. Yeah, all 3 of those ones there. Repeated phrases and words with normal volume. So again, the repetition, and then just showed depression affect. Spontaneous content. That could be some part of catatonia depending on the person's rest of their picture. So we're now going to talk about etiology. So look how smart you guys were. Look at all the stuff you picked up on that thing. Right there. See? You're catatonia experts already. It's awesome. So there are three main etiologies for catatonia, and the first is the one that most of the data supports and is also supported why most patients respond with ECT and benzodiazepines. So for the main etiology, it's too little GABA. So GABA is the inhibitory neurotransmitter in the brain, one of the main inhibitory neurotransmitters. And for patients with catatonia, it's identified that they have too little GABA. Because what do benzodiazepines do? Are they an upper or a downer? They're a downer, right? So they work on GABA receptors to reduce stimulation. Dopamine hypoactivity is a second etiology, and for some patients it's thought that dopamine blockade or too little dopamine is causing this, and this is what the typical antipsychotics particularly focus on, dopamine. So this is why in some of the old literature, the first thing they tell you to do if someone's catatonic and they're on an antipsychotic is to stop it, that they're worried it's actually driving the catatonia. That is the typical antipsychotics like Haldol, Thorazine, Stelazine. The newer data does not indicate that if they're on an atypical that you have to stop. And in fact, there's some case reports of catatonia being treated with people using atypical antipsychotics. Like the patient I was telling you about that had done the thing with her nose and the neighbor's cat's eyes. When she came in the hospital, she was so provocative when she was psychotic. I didn't feel safe in taking her off her antipsychotic, but she was on an atypical, and I treated her catatonia through it. So you can still use atypical antipsychotics. Just make sure you're watching vital signs, that there's nothing funky going on, that there's not starting to creep up heart rate, getting autonomic instability, things like that, to make sure you're not missing something else. And then the third is glutamate hyperactivity. So there's also a subset of patients that it's actually thought to be too much glutamate, and glutamate is the opposite of GABA. Glutamate is the primary excitatory neurotransmitter in the brain. So it's thought that they have too much going on with glutamate, and they would have to reduce their glutamate activity, which I'll talk about when I show you the actual things we use to treat catatonia with. This picture I just liked because it showed about different areas. It showed too little GABA in the prefrontal, too little dopamine over with the ganglia, basal ganglia, and then too high glutamate in another region. So again, probably catatonia is a syndrome, and there's likely different etiologies, probably very similar to how schizophrenia is not the same from schizophrenic to schizophrenic, because it's probably multiple different etiologies. So the treatment, how many of you know what I'm referring to when I talk about mother's little helpers? Oh God, there's only like two of you. The generation gap, it's happened. So do you guys, tell me you at least know who the Rolling Stones are. Oh, well, thank God, that's not so bad. So the Rolling Stones came out with the song Mother's Little Helpers, which was about Valium. It was about benzodiazepines. So the principal main treatment for catatonia is cranking up gabapentin, and then we do that, GABA, and we do that by using benzodiazepines. We traditionally use lorazepam because that's what almost all of the studies were done, because you can give it IV, and it's more predictable than giving someone Valium IV. We give it PO because it's been identified that a lot of nurses are not convinced that's within their scope of practice because they identify it as conscious sedation. So we give it PO on our service. So you start with 1 milligram, and then you look and see how the patient does. If they don't get better, you bump it up. 1 milligram TID. If they don't get better, you go to 2 milligrams TID. If they don't get better, you go to 3 milligrams TID, and so forth, unless you really don't think the person is catatonic, because the most I've had to give someone was 18 milligrams of lorazepam a day. So the trap with this is you give someone a little bit of benzo and they don't get better, you think, oh, they're not catatonic. And the thing that's important for you to keep in mind is if someone comes in DKA and you give them 10 units of regular insulin and their blood sugar does not normalize, does that mean they don't have DKA and that insulin isn't the right drug? No, it means you haven't given them enough. And I think that's the trap, that sometimes it takes a while for patients to get better, and so you bail too soon. So unless there's a reason, like, what's the worst case scenario that would happen if you give someone extra benzodiazepines? Short term, we're not talking about long-term substance. They get sleepy. Maybe they can get delirious, but it's not that easy to get someone delirious on benzos unless they got a really bad brain. So And the whole thing with respiratory depression, you actually look at the data, it really doesn't happen, not unless there's layering. They're on opiates for something that's affecting their respiratory rate, and then you add a whole pile of benzos or something like that. So you treat early, treat aggressively, because I think otherwise you may miss it, and sometimes it takes a while. 70 to 80% of patients will respond to benzodiazepines. That's pretty impressive. ECT, which is actually the gold standard, is more than 80%. So we just have a great example for those of you who are on 5-West-B. We have that court-ordered girl, the woman that we have that's getting court-ordered ECT. I admitted her on the weekend. I worked on July 20th when she came in, and I admitted her, identified she was catatonic, and immediately started treating her with benzodiazepines. We got her lorazepam up. She was in like 12 or 13, I think she was getting a day. We switched her to diazepam because she wasn't having as robust a response as we wanted. Still wasn't looking that great. Her first ECT treatment that we got, she looked markedly better. One ECT treatment helped. So ECT is awesome. What do you think the problem is getting ECT for a catatonic patient? What's the main problem? They can't consent because they're catatonic. So
Still do not consent.
And with her, we're actually continuing to give her benzodiazepines. So she gets flumazenil, which reverses benzodiazepines right before ECT. You'll love this. The second day she was going to get her ECT, they gave her the flumazenil, and she had a seizure. But we hadn't given her ECT yet. She had a benzo withdrawal seizure that second time. So we reduced her benzos. That hasn't happened since. So ECT is fantastic. Sometimes it's a little bit harder. What does ECT do to the brain? ECT causes a huge GABA surge. So that's working on the same currency that you see when you're giving people benzodiazepines. A note about antipsychotics, you may need to stop them, and we talked about this if they're on a typical, but the data really is mixed on this. Other things to keep in mind, if the patient has a psychomotor retarded catatonia, you need to think about all the stuff that you think about for someone who's laying in bed for days and days. So some of you will have remembered working with our Russian gentleman who would get catatonic, who we've given ECT to multiple times. Lots of suicide attempts in his past, very sick guy. The first time I ever worked with him, he just sat in his bed on 5 center like this a month. It took us a month before we could do court-ordered ECT for him. He was so sick. And so you have to think about all this other stuff, right? If someone's not eating or drinking, you're going to have to worry about their nutritional status, their hydration, if they're not moving, what's their skin integrity. So always keep all of those things in mind as well. So what can we do to improve detection? So we have the CAMs. You guys are familiar with the CAMs, the confusional assessment that we use in the ICU to help pick up delirium. By doing this, we've gotten much better at picking up delirium in patients, and then we can treat it early. There's also the CWA. Do we use the CWA in the units ever? We use it like all the time. How often do patients actually go through alcohol withdrawal?
Just had a really bad one.
Like you think about, do you think we have... It's not as frequent as it is ordered, right? Because it's a super bad thing to miss. Like you do not want a patient seizing on the unit. On the other hand, we're actually treating, we do this on patients that it's not that high of a yield and that we don't have this many patients with it. So that's why I think we need to have the CAP. Wouldn't that be awesome? So there's no unit in the country that has a protocol that's done routinely where you automatically screen patients when you have an index of suspicion. So that's one of the things I want us to start thinking about doing as a group, to think what would be a reasonable thing we could do that would help detection but it wouldn't be too onerous for workload. And then once we detected it, then we could get a protocol initiated so we could get going on things, get these patients identified sooner, get them better, get them out of the hospital sooner. So this would be the proposed treatment algorithm. Lorazepam because it's easiest. It's hard to get ECT right away. And then thinking if the patient's having a partial response or is getting too sedated, you could do an alternative benzo like Valium. You could do Zolpidem, Ambien. So a subset of patients that have a partial response to benzodiazepines actually will have a response to Zolpidem. And it's so interesting. You give them the sleeping agent and then they wake up. And I've got patients that get 15 milligrams a day, 5 milligrams a half an hour before meals so that they can talk and eat. It's amazing how it works. It works the opposite of the way you would think it would work. Works on benzodiazepine receptor, GABA receptors as well. Memantine, topiramate, or amantadine can be used for that subset of patients that have too much glutamate, for that third etiology, and then ECT we talked about. So take-home points. Catatonia is common, and I think we miss it a lot. I think we're a lot better than we used to be, but still I think we're not seeing it as much as it is there. And there's good things available to use, tools to help you pick it up. And then once we pick it up, we need to get going on treatment because we can get these patients feeling lots better, lots faster. Thank you, guys.
Thank you.